Good morning to everyone. I'm Fabio Silvio from Brussels, and the topic today will be the role of automated pupillometry in brain injury patients. These are my conflict of interest for this talk. So we know that pupil examination is extremely relevant to assess brain injury patients in the ICU. In the ICU, it can give us an idea of the severity of the injury. It can help physicians to ask for additional testing, adjust sedation and analgesia, and in some cases even initiate therapies, in particular for increased intracranial pressure. What we do in practice is looking at size, anisocoria, looking at right reflex, but all these parameters are assessed in terms of quality. Pupillary size is imprecise, anisocoria is probably yes, and right reflex is present or absent. It's not a quantitative analysis. The pupillometry allows a quantitative assessment of pupillary function. And pupillometry, by the way, is more precise than just the physician examination of the pupils to assess size and anisocoria. In this French paper, where different physicians evaluated the size and the difference in pupillary size between left and right in brain injury patients, we can observe that the discordance between the device, which is of course the gold standard, and the clinical examination could increase up to 20% in terms of pupillary size, and up to 1 patient out of 2 who had anisocoria could not be adequately identified just using clinical examination. The other point is that pupillometry can give you a lot of additional information. For example, the rate of constriction of size reduction, the velocity of constriction, the velocity of dilation, and can give you so many information on the quality of pupillary function that you can really look at the pupils as a quantitative value, as we have for heart rate, blood pressure, of oxygenation, and then pupillary function can become a vital sign we use continuously or almost continuously at the bedside. Now, how to use it? Well, specifically for brain injury patients, looking at the structure and the anatomy of the pupillary light reflex, we can use it to extend brainstem function in brain injury patients, in particular the mesencephalon function. What we know is that when there is an increase in ICP, especially with midline shift, there is a compression on one side or two sides of the mesencephalon. And the first alteration, far before the anisocoria, is a reduction of the constriction velocity when we assess the pupillary light reflex. The point is that the constriction velocity, as other parameters of the pupils, is dependent of sedation and analgesia. And as most of these patients with brain injury concomitant to receive sedation and analgesia, we can of course argue that looking at these parameters, we could have some bias into the accuracy of these parameters to assess a surge of ICP. This is why some companies have integrated into the pupillometry an index like the NPI, the Neurological Pupil Index, which is independent on the sedation and analgesia, and basically is a quantitative assessment of pupillary function going from 0, no function, to 5, perfect function. More than 3 are values that are observed in healthy people, and you can, in that case, evaluate a normal function of an altered function, less than 3, and then get an evaluation of pupillary function, which is independent of drugs received by the patients. Just in terms of ICP, in this patient coming from Switzerland, looking at 54 patients with TBI, you can easily see how the changes in TBI mirror the changes in ICP. ICP goes up and MI goes down, even before ICP exceeds the values of 20 millimeters of mercury. And for those patients receiving osmotherapy in this side, ICP goes down, and again, NPI goes towards normal values. So you can use repeated measure on NPI to assess the effect of therapies and the surge of ICP. And we have confirmed this data in studies coming from our group, where 100 patients were measured, ICP and NPI. You see this correlation, quite acceptable correlation between NPI and ICP, a quite fair, acceptable accuracy to predict increased intracranial pressure for NPI in this large heterogeneous population of brain injury patients. Because we can assess brainstem but partially also cortical function, this pupillary assessment through the pupillometry can give information about prognostication. About TBI, this is the paper from Switzerland. you can see that the greater time spent with abnormal repeated NPI values was observed with patients with the poorer outcome. So again, the importance to repeatedly assess pupillometry and assess NPI, and when these NPI values are repeatedly altered, this can identify patients with a high probability of poor outcome. In SIH patients, what these authors have observed is that NPI can be altered hours before patients show clinical signs of delayed cerebral ischemia. So the alteration of NPI at individual patients level could be used to identify patients who will deteriorate thereafter. In these patients, in this subgroup of patients with ECMO, again from Switzerland, the authors have observed that the trajectories of repeated measurement of NPI is very relevant. If NPI is always normal, only 43% of patients will have brain injury. Patients who show NPI recovery from pathological values have 40% of brain injury, while patients with consistently low levels of NPI, or where there is a deterioration of NPI, they have almost all a 1% of poor outcome, and an NPI less than 3 at 24 to 72 hours have a 100% specificity to predict poor outcome in this patient's population. Where the role of prognostication of pupillometry is been well studied is in cardiac arrest. We know that pupillary function is considered as a strong predictor, and as we know that with the pupillometry we can more adequately assess the pupillary function, we have performed these multicentric studies, 456 patients published in Intensive Care Medicine 2 years ago, where we have observed that an NPI less than or equal to 2 already at day 1 had 100% specificity to predict poor outcome in these patients. And the main results of these studies is that NPI, which is an index of pupillary function, is already a strong predictor of poor outcome at day 1 after cardiac arrest. This index is more accurate, just the constriction to the light, the pupillar right reflex, in terms of accuracy to predict outcome in this patient's population. And if you combine NPI and evocate potential, of course, specificity remains 100%, and the sensitivity can be increased up to 50 to 60%. And this data has been partially confirmed by smaller monocentric trials where a low NPI has been associated with 100% specificity to predict poor neurological outcome in patients after cardiac arrest. The last point is that as there is a connection between the visual pathways, the mesencephalon, and through the lateral geniculate nuclei to the visual cortex, there might be an issue where the quantification of pupillary function can also give information about cortical function. In ICU patients, which is the way to better assess cortical function, or some of the ways we can assess cortical function. On the clinical sides, we can use delirium, very frequent in mechanical ventilated patients, and on the monitoring side, on the more objective side, we can, of course, use EEG, which is probably the best way, the best monitoring way to assess cortical function in ICU patients. So again, just to present you some data, this is a study from Switzerland, where there is 100 patients, medical patients with mechanical ventilation, and being followed and monitored by automated pupillometry. You can observe a lower pupillar light reflex constriction rate, a lower constriction velocities in patients developing subsequently delirium when compared to patients without delirium. After adjustment for sulfa and the use of sedative opioids, this author shows that a reduced quantitative pupillary light reflex at day 3 was associated with an increased likelihood of ICU delirium. So this tool could be very interesting to identify patients undergoing mechanical ventilation, which will receive very few monitoring tools to being at risk to having delirium thereafter. And this is a study coming from my group in Belgium, where we compare the pupillometry information to the EEG in the heterogeneous population of critically ill patients, 60 patients, a proof of concept study. What we have observed is there is differences of pupillary constriction rate, for example, according to the different encephalopathy assessed blindly to pupillometry by the neurologist. And the worst is the cortical function, severe encephalopathy burst suppression. The lowest is the pupillary constriction. And when you combine these two as being an reactive EEG, a constriction velocity less than 20%, as an area under the curve of 0.83 to predict an unreactive EEG, which means pupillometry could be used to identify a poor pattern of EEG function or patients at risk of having a poor function, and maybe this patient would deserve an EEG monitoring if not initiated yet. So in conclusion, just a brief summary, I would say that the use of automated pupillometry should be routinely implemented in clinical assessment in brain injury patients because it's more precise to assess pupil size and anisocoria in this patient population. It could be useful in the management of brain edema to understand the effect of increased ICP on the brainstem function, in particular when we look at the NPI. A repeated NPI measurement can be used also to look at the effectiveness of therapy on reduction of ICP and reduction of potential herniation on brainstem. Third, there is a role of automated pupillometry to assess neuroprognostication. There are few data on TBI, SAH, and ECMO. The more relevant data are in cardiac arrest, and we wait next the guidelines to see how the pupillometry could be potentially implemented in the next prognostication guidelines for anoxic brain injury. And fourth, there are some initial studies suggesting a role for pupillometry to assess cortical function, either predicting delirium or predicting being associated with an unreactive EEG. And so the future will be to implement, of course, the automated pupillometry in the large numbers of neuromonitoring, invasive, non-invasive tools to better understand brain physiology and function after an acute brain injury. Thanks a lot.